Good morning, everyone. So today the first topic for the day is diagnostic biomarkers in biliary atresia. Now the current diagnosis of biliary atresia is based on a combination of clinical findings, finding of high GGT in the lab, ultrasound findings, and then the confirmation of the diagnosis by liver biopsy and cholangiogram. Now, while the per-operative cholangiogram was considered the gold standard and is still considered the gold standard for the diagnosis of biliary atresia, the cholangiogram can also be done percutaneously to prevent negative laparotomy rates. And this was the paper that we published about percutaneous cholangiogram, and where we showed with the help of the IR team that the cholangiogram can be done through the percutaneous route, and if the dye goes into the duodenum as well as into the proximal biliary tree, then the biliary atresia is completely ruled out and you can prevent negative laparotomy in such cases. However, the problem arises in such cases where the dye goes into the duodenum but doesn't go upwards into the common hepatic duct, LSD and RSD, where a diagnosis cannot be made between biliary atresia and other similar conditions. So, this percutaneous cholangiogram can correctly differentiate biliary atresia from non-biliary atresia causes in around 92% as per our study. Then this Dr. Archana's paper from 2009 still holds true and guides our diagnosis of biliary atresia based on liver biopsy, and biopsy findings have sensitivity and specificity of around 89%. A recent paper using quantitative CK7 has shown that in difficult cases, the sensitivity and specificity can be increased by using this quantitative CK7. This is from one of the pathology residents. So the three findings that we use: portal expansion by loose edematous fibrosis, bile ductular reaction and ductular bile plugs, are actually not pathognomonic of biliary atresia, but will be found in any case of biliary obstructions. These are findings of biliary obstruction and not biliary atresia per se. So any other disease causing biliary obstruction will have similar histopathological findings. Ultrasound, there are a lot of advances coming up, mainly with the use of AI to improve the diagnostic yield of ultrasound, which has good sensitivity but very poor specificity. And in ultrasound, this is a recent project which we have joined. The project was started by the Houston team, where they are aiming to see the duct at hilum. And this project we are doing with Dr. Amar, where we aim to look for the duct near the main portal vein by feeding the child right at the time of doing ultrasound, so that the duct fills up and is seen. But as of now, we are not finding it again to be very specific. Again, we are finding good sensitivity, but specificity part is not helping out with this method also. So that is why, with the limitations of the current diagnostic method, that is biopsy around 90% sensitivity and specificity, cholangiogram difficult and invasive, biopsy again invasive, and ultrasound which has very low specificity, there is a need for molecular diagnostic biomarkers test which can be done in serum, in urine or in stool, and help diagnose biliary atresia. Because rapid diagnosis is early, the turnaround time from admission to a Kasai surgery has to be very less, ideally within 3 to 4 days, because most of the time the children are referred late and Kasai surgery has to happen as early as possible. So before going and understanding the molecular basis for diagnostic biomarkers, we have to understand the pathophysiology of biliary atresia, which will guide which are the diagnostic biomarkers. So the pathophysiology of biliary atresia I have tried to simplify, and it can be divided into 5 steps. First step is in the prenatal period. In the antenatal period, there is injury to the cholangiocyte by some trigger, which leads to activation of innate immunity, which then leads to adaptive immune response, which is auto-amplification and persistent injury despite the removal of the trigger, followed by progressive cholangiocyte loss and bile duct obstruction, ultimately resulting in fibrotic obliteration of the bile duct and fibrosis of the liver due to biliary obstruction. If we go by steps one by one, injury to the cholangiocyte, the triggers which have been most strongly believed right now are the viruses, which are reovirus, rotavirus, and in some cases CMV. Toxins, it is proven in zebrafish models but not in human, biliatresone, and then there are genetic factors like PKD1L1 and several other genetic factors. Once there is injury to the cholangiocytes, there is activation of innate immunity. Now at the cellular level, the cholangiocyte, these green ones are the cholangiocytes, are the first responders. Upon exposure to the viral components, the TLR3 and TLR7, which are the pattern recognition receptors, are activated. This triggers NF-kappa beta and type 1 interferon signaling, leading to transcription of pro-inflammatory cytokines. Mainly the most important cytokine here is interleukin 8, TNF alpha and MCP1. This also leads to Kupffer cell activation. The same triggers lead to release of PAMs and DAMs, and these PAMs and DAMs lead to activation of Kupffer cells. And among the earliest infiltrating effector cells are natural killer cells, which respond to type 1 interferon and interleukin 15. Now apoptotic cholangiocytes release DAMs, which I already said, and even if the viral trigger is now cleared, a self-amplifying innate loop persists, perpetuating inflammation and tissue injury. Now next, coming to the adaptive immunity. Now the basis of adaptive immunity is mainly Th1 response. So the interferon 1, type 1 interferon response through IL-8 leads to activation of Th1, and recently there is evidence to suggest that there is some Th17 response also. So now this Th1 will lead to further activation, further activation of the macrophages, Kupffer cells, and conversion of these activation of these portal fibroblasts, which convert into myofibroblasts. So the next step from activation of the activation of the adaptive immune response is cholangiocyte loss and bile duct obstruction. Now this is a schematic diagram I have tried to make to simplify things, that once there is a Th1 response, the main cytokines which are released are TNF alpha, interferon gamma and interleukin 12. These lead to activation of hepatic stellate cells and portal fibroblast. At the simultaneously, they are also leading to Kupffer cell expansion. Now hepatic stellate cell and portal fibroblast are converted into alpha smooth muscle active myofibroblast, which release collagen type 1 and type 3. This collagen type 1 and 3 gets deposited, leading to extracellular matrix remodeling. At the same time, deposition of collagen 1 and 3 around the portal vein and hepatic artery leads to hypoxia, which will lead to release of this VEGF and other angiogenic growth factors, which lead to angiogenesis and further ductal action. There is also a role of Notch pathway and Wnt beta catenin pathway. The Notch pathway, as we all know, leads to cholangiocyte hyperplasia, while Wnt beta catenin pathway in this pathophysiology leads to activation of MMP7, which cleaves E-cadherin and remodels the matrix, ultimately leading to both of these combined, leading to ductular reaction and ductular obstruction, ultimately leading to progressive fibrosis. There is a role of osteopontin in amplification of this inflammation. So now if we see the pathway, the diagnostic biomarkers have to be one of the cytokines involved in this adaptive immunity. It could be MMP7, it could be osteopontin, it could be one of the markers of fibrosis. The problem with markers of inflammation would be it would be non-specific to biliary atresia. Any injury will lead to this adaptive immunity and inflammation, but most of the neonatal bile duct injury do not lead to progressive fibrosis. So markers of fibrosis deposition, fibrosis expansion would be more specific to biliary atresia, is what we would believe based on this pathophysiology. So let's go ahead and see what has been done in the studies. Starting from the simple biomarkers, we'll come to those biomarkers later, but first starting from a simple biomarker, that is conjugated bilirubin, and this was a very important paper by Harpavat from Houston. So he showed that conjugated bilirubin is elevated right at day 2 or day 3 in children with biliary atresia. Now they had the advantage that they keep the sample from day 1 or day 2 of the life, and these samples are preserved in Texas. So they took out the samples, they took out the birth samples, the day 1, day 3 samples of patients with biliary atresia, and found that the conjugated bilirubin was elevated right at day 1 or day 3 in these children. And so on the basis they found that while 35 children with biliary atresia, all 35 of them had elevated conjugated bilirubin at day 3 of life, with sensitivity was 100%, and among those without biliary atresia, only 166 children had an elevated conjugated bilirubin at day 3, amounting to a specificity of 98.2%, which further increased if these children had a repeat testing at day 14. This is a part of prospective study that I am showing. The retrospective study I have not shown here. So going further, they also showed in a recent study that it is possible to test the conjugated bilirubin in cord blood, and cord blood conjugated bilirubin was correlating with day 1 or day 3 heel stick conjugated bilirubin levels. Now the earliest molecular marker which has been explored in proteomic studies, in genome-wide association studies, was interleukin 8 expression in the liver. So this study showed that interleukin and LAMC2, which is a form of laminin, are highly expressed in the liver in biliary atresia, and had a good sensitivity and specificity for diagnosing biliary atresia and differentiating it from other causes of neonatal cholestasis. But as we can see in the lower part, the serum IL-8, because we want the biomarker to be available in the serum. So in the serum, IL-8 in biliary atresia was not different from the IL-8 in non-biliary atresia cholestasis. So IL-8 and LAMC2 were highly expressed in the liver tissue in biliary atresia, but the response was not systemic, and you can see the area under curve is quite low for IL-8 in the serum. Now the one molecular marker, biomarker, which is coming up, which has actually already been evaluated a lot, is MMP7. Now, as we already discussed, MMP7 was involved in the pathogenesis of biliary atresia in the step after adaptive immunity, when the fibrosis of the bile ducts and obstruction of the bile ducts was happening. So here, this experimental study in mouse models shows that if the mouse are given RRV, that is rhesus virus, so this rhesus virus is known to generate biliary obstruction in the mouse model. So you can see here that if you give RRV to the mouse, by day 7 the MMP7 increases in the bile duct, and by day 14 MMP7 increases in the liver. That means after giving RRV, first the injury is happening to the cholangiocyte by day 7, and by day 14 cholangiocyte obstruction is leading to injury to the liver. Now this can also be proved by further studies where they showed that if RRV was given to the mouse, the duct has not formed, as you can see in the first panel, but in the third and the fourth panel, where RRV was given with an MMP inhibitor or a MMP7 antibody, and you can find out now that as MMP has been inhibited, the duct has formed despite administration of RRV. This can also be shown here, that when RRV was given, 100% of mice had bile duct obstruction, whereas when RRV was given with MMP inhibitor or with an antibody, only 14 to 18% of mice had bile duct obstruction. So this shows that MMP7 also has a possible, this adds on to the evidence that MMP7 has a role in pathogenesis of biliary atresia. We can also see here in this MMP7, immunostaining is more strongly seen in the extrahepatic bile ducts of biliary atresia compared to neonatal cholestasis and alpha-1 antitrypsin deficiency, which is a very strong and very close differential of biliary atresia in the Western world. Now this study was a large-scale proteomic study which showed that among all the protein markers which were evaluated, MMP7 was the best to differentiate biliary atresia, shown by this red color, from non-biliary atresia neonatal cholestasis, shown by blue color. The black color are the healthy controls. So you can see that other markers like IGF, BP1, collectin kidney 1, ENPP, everything, all other markers did not show such a strong correlation as was seen with MMP7, and you can see the AUROC for MMP7 alone for differentiating biliary atresia from other causes of neonatal cholestasis was close to 94%, and this was not improved by addition of other biomarkers like ENPP7, GGT or any other thing. they did subgroup analysis whether MMP7 increases with age. That was what is believed and has been shown in some studies, as I will be showing. So they showed that whether it is possible to diagnose biliary atresia as early as less than 60 days of life, because that is when you want to diagnose biliary atresia. And even in children less than 60 days of age, biliary atresia children had a higher serum MMP7 level than non-biliary atresia cholestasis, as you can see in this part, and healthy controls have absolutely normal MMP7, meaning that in absence of a biliary injury, MMP7 does not rise in the blood of these infants less than 2 months of age. Now, this is a multicentric study from USA on MMP7, and they showed that using 2 different kits, they showed that the sensitivity, the AUC was almost comparable to the first study, around 90%. The sensitivity was 94%, that is around 6% of biliary atresia still had MMP7 less than the cutoff, and specificity was low in this study, was only 78%. That is a significant number of other disorders like choledochal cyst, alpha-1 antitrypsin deficiency and indeterminate cholestasis can have elevated MMP7. Now, this was a dampener on the MMP7 studies going all over the world. There is only one Indian experience. This is from AIIMS, and they showed a small study in around 32 or 34 patients. They showed that at a cutoff of more than 5, MMP7 level could differentiate between biliary atresia and other causes of neonatal cholestasis. This hepatology study 2018, just after the 2017 study from the same group, had shown that apart from serum MMP, the MMP immunostaining in liver can also be used to differentiate biliary atresia from all other causes of neonatal cholestasis. However, there was no clear correlation between liver MMP7 intensity on x-axis to the serum MMP level on the y-axis. There has been a spurt of studies on MMP over last 4 years, since 2020 or 21. Mostly they are Chinese study, except one or two, one multicentric US study, North American study, and one European study. Almost all others are Chinese study. And this recent meta-analysis showed that the pooled sensitivity was 93% and pooled specificity was around 85%. So this is again suffering from the same problem that our GGT, that our ultrasound finding, that our liver biopsy was suffering, that was lack of specificity to differentiate from other similar causes of biliary obstruction in neonatal cholestasis. So not everything is good about MMP7. There are challenges, as we can see in this tabulated form, that the cutoff of MMP7 is varying between the various studies from 4.5 to 26. Now, that is a very wide cutoff for use in clinical practice. Now, if we believe that this is due to the different kits that are being used, that is the most likely explanation for the same. But still, if you see, here the kits are same in all 3rd, 4th, 5th and 6th study. Duoset R and D, the same kit has been used, and the cutoff obtained has been 4.5, 7.8 and 18.6. So, the cutoffs are different. This could be due to the population heterogeneity. It could be due to the controls which have been used to arrive at this cutoff. So, the major problem is standardization of the kit and getting a cutoff in your population, what cutoff works in your population, and that is why MMP7 is still not in with the kind number of studies that have come up. It should have been in clinical practice by now, but it is still not because of these limitations. And this limitation was also shown by this multicentric North American study, that when they use the Luminex kit and FRET kit, sensitivity and specificity remain same, but cutoff was different. With the Luminex kit, it was 52, and with the FRET kit, it was 18.2. So the cutoff was varying. Also, you can see here, this one study has shown that if we compare the various etiologies which were used as controls in the non-biliary atresia cholestatic controls, you can see that biliary atresia has very high levels of MMP7, but simultaneously PFIC group, which are genetic intrahepatic cholestasis under a closed differential, are also having highly elevated MMP7. Although this should not be a challenge, because biliary atresia is high GGT cholestasis and PFIC are low GGT cholestasis usually. So that should not be a challenge. Now, the third challenge that we are talking about is, does MMP7 change with age? And here the European study has shown that MMP7 actually increases with age. Now this is a healthy control. In healthy control, they are showing that MMP7 was high initially and then decreased with age. But if you forget the upper panel and see the lower panel, you can see that MMP7 in biliary atresia is increasing with age. That means that as the biliary injury is progressing, MMP7 levels are rising. But thankfully, this change is not much in the first 60 days of life, because the fibrosis is not setting up that much in the first. Various cutoffs ranging from 5 to
18.
10, 18, 26, but
Now
I will go somewhere median range. It can go in up to 100, but most of the range will remain around 30, 40,
30.
50, 60.
So now the next slide which you are showing, yeah, this one, the MMP7 levels in the biliary atresia are 100, 200.
Yes, sir. This is the Luminex kit where the cutoff obtained was 52.8. So this is that kit which has been used.
Hugely variable.
Yeah, very variable. That is the main limitation, I believe. Other markers quickly. So osteopontin, which was again I showed in the pathophysiology that it is an amplification of and a bridge between the inflammation and fibrosis. So osteopontin was evaluated but was not found to be very good compared to MMP. Very low accuracy for differentiating, discriminatory accuracy. Cytokines have been evaluated. Most importantly, the Th17 cytokines like MIP3A, interleukin 33, etc., are a combination of these cytokines. And the best accuracy was with MIP3A, but again the sensitivity specificity is quite limited. Specificity around 80%. IL33 again pooled sensitivity around 77%, pooled specificity around 85%. So you can see that. Interleukin 8, there was one study I showed previously that serum IL-8 was not different between biliary atresia and non-biliary atresia, but here one study is showing that although there is significant difference between the levels of IL-8 between biliary atresia and non-biliary atresia, but you can see there is a lot of overlap between the two groups. So again, not a very good marker. Now there are other studies coming up. This is a recent study, proteomics, two-step proteomics approach, one using MS technique, and the second step is targeted method to validate the proteins found important using MS technique. And in this they found that 33 proteins were found different, overexpressed in biliary atresia or underexpressed in biliary atresia. And among those 33, these are immunoglobulin related, were significantly different between biliary atresia and non-biliary atresia. Now this study actually questions the pathophysiology, because all the pathophysiology I talked was about T helper cells, so T cell related injury, but this is showing that there could be some immunoglobulin related, B cell related injury also happening in biliary atresia, which we are not very sure yet at what level does it happen, the antibody mediated injury. Can biliary atresia be diagnosed like other disease in newborn screening, as a part of newborn screening, when we are already taking samples, especially the Western countries, for other congenital disease? Can we do it in the dried blood spot from the newborns? And such studies have evaluated and found that mainly the bile acids will be elevated. There is biliary obstruction, so the primary bile acids like taurocolic acid and glycocolic acid will be elevated in biliary atresia, and this can be used in the neonatal newborn screening program. That also is there in other studies, but both of these are elevated in.
No.
So I'll quickly go ahead. A microRNA, we all know, are small non-coding RNA which are stable in serum or bile, and that's why they can be detected easily. There is a tissue-specific microRNA which is 122, and so the studies have evaluated but found that although it is elevated in biliary atresia microRNA 122, it is also elevated in other non-BA causes of cholestasis. What was significantly different was under-expression of microRNA 140 in biliary atresia compared to non-biliary atresia cholestasis. This is microRNA 122 which was elevated compared to normal, but this is compared to normal controls and not compared to cholestatic controls, and thus cannot be given that much importance. Coming to other biomarkers, amyloid precursor protein, I'll skip this for now, which is elevated in biliary atresia. Coming to other things that can be seen apart from serum. So duodenal aspirate, it is easy. So biliary atresia, bile is not being released into the duodenum. So if you take the duodenal aspirate, the bile acid level should be very low. So you can see here that the bile acid level from the duodenal aspirate was very low in biliary atresia compared to non-biliary atresia. Again, a very simple test, but difficult to obtain bile from the 30 or 60 day old neonate with putting a tube. Then coming to stool biomarkers. Now if the bile duct is atretic, the bile will not be released in the duodenum and not be present in the stool. So if you do the stool biomarkers, you will find in biliary atresia that the bile acid levels will be very low in biliary atresia compared to controls and other cholestasis. And you can see that the cholic acid, sorry sir, that was not in serum, that was in stool I was talking about. In stool, cholic acid and chenodeoxycholic acid will be low because they are not being released in the bile. And same about the ratio of Ca and CDCA, which will be very low in biliary atresia as compared to other causes of cholestasis. I don't have other studies on serum levels of these bile acids. But there are obviously very main limitation of stool biomarkers is that LC-MS takes is not a routine clinical equipment, and turnaround time will be the key. So other stool biomarkers which I evaluated are shown that there are rise of inflammatory proteins in the stool and loss of digestive enzymes in the stool, which are but obvious. Why? Because of the biliary obstruction. Urine biomarkers, markers of N-acetyl D-manosin and alpha amino adipic acid have been shown to be elevated in urine of biliary atresia. So to summarize, the routine biomarkers that we have are direct and conjugated bilirubin, which is simple to do. The protein biomarkers which have maximum evidence are MMP7 with a lot of meta-analysis coming up, but it needs standardization in the lab, and the cutoffs need to be defined for your population, your technique and your standardization. Osteopontins, then there are cytokine biomarkers which have failed, obviously because inflammation is not very specific thing to biliary atresia, and any neonatal bile duct injury will lead to activation of the inflammatory markers. Proteomics, metabolomics and microRNA are the way forward. Transcriptomics, amyloid precursor protein, and then body fluid biomarkers like duodenal aspirate, stool proteomics and urine metabolomics may be the way forward. So conventional diagnosis are invasive. We need molecular biomarkers. MMP7 is the most validated and practical serum biomarkers. Integration of molecular markers with the imaging and clinical findings may guide future diagnostic algorithms based, and AI can be used for developing an algorithm based on combining all these things together. And whatever the method we obtain has to be rapid to give us diagnosis so that early Kasai can be done, and has to be point of care assay so that quick results are obtainable. And obviously omic studies are feasible, and somehow we have not tried this, but should be done at ILBS. Thank you.